Okay, we will go ahead and get started. Again, good morning and good afternoon and good evening from wherever you're joining today. Thank you so much for joining us today for this webinar, Resources for Examining the Costs and Cost Effectiveness of Social and Behavioral Change Interventions for Health. Next slide, please. So we have a great agenda for today's webinar, which is really meant to launch an active community of practice around costing for social and behavioral change, fostered by Breakthrough Research, USAID's flagship social and behavior change research project. In just a moment, I'll introduce the speakers for today, and then we'll dive into the agenda and talk about the importance of SBC costing, highlight costing resources developed under Breakthrough Research, note the challenges that come with conducting SBC costing and cost effectiveness studies, explore how unit costs are defined with an applied example from the Moneros campaign, and then look ahead to what's next as part of this costing community of practice. Next slide, please. So we're really eager to hear from you today, and we'll have a question and answer session at the end. Please feel free to put your questions in the Q&A section of the Zoom window, and these can be entered in English, French, Portuguese, or Spanish. And we'll monitor these questions throughout the webinar and answer as many as possible, either by chat or during the Q&A session. And those questions that are not answered during the webinar will be posted to Springboard, our online community of social and behavioral change professionals. Next slide. So thanks again for joining us today. I'm Amanda Kalamar, the Technical Director for Breakthrough Research at the Population Council, and I'm joined by 5 outstanding panelists. Avery, Avrakotos from the U.S. Agency for International Development, Lori Bollinger from Avenir Health, Shitu Abdu Aguye from Breakthrough Action Nigeria, Nicole Bellows from Avenir Health, and Michelle Schwanch from Avenir Health. So we'll get started, and Avery, over to you.
Thanks, Amanda. Welcome, everyone, and good morning, good afternoon, and good evening. My name is Avery Avrakotos, and I am Malaria Technical Advisor with USAID. In that capacity, I serve as team lead for the U.S. President's Malaria Initiative's Interagency Social and Behavior Change team. It is my privilege to welcome you today for what I know will be an interesting and informative presentation. For those of you not familiar with Breakthrough Research and Breakthrough Action, Breakthrough Research and Breakthrough Action are USAID's global flagship social and behavior change projects. As sister projects, Breakthrough Research and Breakthrough Action collaborate closely and aim to advance the use of social and behavior change to encourage people around the world to adopt healthier behaviors. For Breakthrough Research, this involves the generation, packaging, and use of innovative SBC to inform programming. The project timeframe spans from 2017 to 2022, so we are in the 4th year of this 5-year project and have generated a lot of exciting insights to date. Today, we are focusing on one of the key technical areas under Breakthrough Research, which looks at costing and cost effectiveness. Next. Coming from a donor organization, the issue of costing and cost effectiveness is one that is near and dear to my heart. As part of my work with the U.S. President's Malaria Initiative, I work with country teams across 27 countries to make decisions about the appropriate level of investment in social and behavior change interventions. In a resource-scarce environment, these can be incredibly challenging decisions, and often they are made all the more so by a lack of high-quality information on the costs and cost effectiveness of social and behavior change interventions. For USAID, this can be a significant challenge because while we know that social and behavior change is a key component of ensuring the adoption and maintenance of key health behaviors, it can be hard to justify those investments or even know how to plan. In the absence of evidence of high quality evidence on the cost and cost effectiveness of social and behavior change investments. This limitation makes it difficult to place social and behavior change at the forefront of planning efforts, whether our own or those of host country governments. As a result, it's all too common to find SBC insufficiently represented in national planning documents like costed implementation plans. For this reason, USAID is particularly excited about breakthrough research efforts to build the evidence base around the cost and cost-effectiveness of social and behavior change. The project's focus on demonstrating the value that SBC brings to health programming will help advance advocacy for continued or increased SBC funding, and will facilitate budgeting and planning by synthesizing existing information to give a sense of the costing benchmarks for different types of SBC interventions. Perhaps most importantly, as we gather more data on cost effectiveness, we're beginning to see patterns of which type of interventions are most cost effective in achieving specific health goals and in certain contexts. This, in turn, will help us allocate scarce resources more effectively. At USAID, we certainly acknowledge that this work is challenging, but we want to encourage you all to work together on grappling with these challenges so that we can move the field forward in demonstrating the value that SBC brings. With that, I want to turn the presentation over to Lori Bollinger with Breakthrough Research, who will provide an overview of costing resources developed under the project to date.
Thanks, Avery, and thanks, Sherry, as well, for your overall introduction. And hello to everyone who's on the webinar. So I want to give you a brief overview of what Breakthrough Research has been working on with respect to cost and cost effectiveness over the last few years. Next, please. Thought the first thing would be to go through just a couple of definitions. So first, costing. What is costing? Costing is collecting the data and analyzing it to estimate the cost of a health intervention. Now, costing needs to be done using a standardized approach based on widely accepted methodological principles. So what is cost effectiveness analysis? That's when you bring together the impact evaluation of an intervention with the cost. So you divide the costs by the changes in behavior to calculate an incremental cost effectiveness ratio, or ICER. So this is where the impact information enters into this kind of analysis. And of course, as Avery was just saying, it's important to look at cost effectiveness analysis. But I also want to emphasize that if you want to calculate an ICER, it's not enough just to have the impact. You also have to know the costs. And that's what we've been working a lot on under Breakthrough Research. Next, please. So there have been two main areas that Breakthrough Research has been focusing on with respect to costing and cost effectiveness. First, we synthesized existing evidence, and we did that through both doing a literature review and then building a repository of costs. And then we also have implemented both the costs and the impacts found in the reviews to construct SBC business cases by health area. We've also been generating new evidence. So in order to do a proper costing, it's important to have good guidance on how to conduct the costing analyses. So we developed this guidance. And then our last piece is then we've been actually conducting both costing and cost effectiveness studies under Breakthrough Research. I'll go through each of these in a little bit more detail. Next, please. So first, the synthesis. We conducted a literature review of SBC costs and found 147 cost studies across all health areas, and they contain 867 separate cost estimates. That's because sometimes you would have a cost bite for a different type of provider or a different country, those kinds of dimensions of the cost. So most of the costs, or a subset of the information associated with costs, we then incorporated into the Global Health Cost Consortium's Unit Cost Study Repository, or UCSR. Now this is a resource, it's a standardized way of displaying cost data across health areas. So we have HIV, TB, SBC, and family planning. The link you can see is right there. You can sort, there are different data visualizations available. So it's a nice resource if you want to do some analysis of costs. There is also this full database, which provides the complete details on the intervention, the cost components, and the methodological aspects, and even some impact data if there were associated impact data with the study. And so a little bit further information on each of the studies, and the web address where that's available is also shown here. Next, please. So I just wanted to do a brief, I just want to go through this quickly. So when you go to that ghcosting.org and you land on the UCSR page, you can see it's been designed to be very easy just to check your filter. You would check SBC. There are several secondary areas, and then you check the specific intervention that you want to look at. There are other filters, of course, that you can also implement if you want to. Those are the only 3 that are required. Next. And then this is the resulting display. So you see all of these things organized, and they've all been vetted and checked. There are further study attributes you can see on the secondary pages on the right. And then there are also data visualizations, as I had mentioned. Next, please. Another resource we developed is an interactive infographic that synthesizes the evidence about impact. So the web link is, again, down at the bottom left-hand side. And basically, when you click on any of these buttons on the left, you can see the evidence and the resulting increase in modern CPR from these SBC interventions, and you can see the intermediate impact, the pathways, including the intermediate impacts. So I encourage you, that's another resource that's very, very helpful. Next, please. So we combined all of this costing research with effectiveness to build models that combine those 2 pieces, the numerator and denominator, to look at the cost effectiveness, the relative cost effectiveness of interventions. So we built these business cases for SBC, for family planning, and malaria, and they're both available. And both found that SBC investment scenarios are highly cost effective, according to the WHO criteria of less than 1 times GDP per capita. And we're just starting to build a new business case on SBC interventions for nutrition. Next, please. Then let's go to the second bucket of activities, which was generating new evidence. Now, as part of the Global Health Cost Consortium, one of those products was the guidelines for costing global health interventions in general. So under Breakthrough Research, we adapted those guidelines to costing social SBC health interventions. There are 17 different principles organized into 4 different categories, and these follow, again, they follow the GHCC global health costing guidelines. And again, I encourage you, the link is down below, and I encourage you to explore those. They're very clearly written and I think very helpful. Next, please. So our final set of activities is applying these guidelines in a couple of different ways. So we're doing cost-effectiveness studies on integrated SBC approaches in Nigeria, and we're also doing another one in the Sahel, both in cooperation with Breakthrough Action, who have been great partners in doing this work. And I just want to make one more point, which is one of the benefits of the work that Breakthrough Research is doing is that the planning for these costing and cost effectiveness efforts, because we've been working in conjunction with Breakthrough Action, the design has begun at the beginning, in the early stages of the program evaluation, instead of at the end. So in the same way and this is my pitch, and what I keep saying on SBC calls is, in the same way that you plan for evaluating impact at the beginning of a project, you also need to plan for the costing piece at the beginning of the project, because you need to have accounting systems in place to track the data that you are going to need in order to calculate the cost effectiveness ratios when you combine the costs and the impact data at the end of the evaluation. So I think that's my last slide. And of course, happy to take any questions now or via email. And now I'll hand it over to Shitu, who's one of our colleagues at the one of the evaluations for the Breakthrough Action Nigeria program. Over to you, Shitu. Thanks.
Yeah, so thank you, Laurie, and good morning, good afternoon, everybody, depending on where you are in the world. I will start by just reiterating a point that has already been made, that cost effectiveness, SBC cost effectiveness studies elevates the role of SBC in programs designed for improving health outcomes, and really supports advocacy for continued funding for SBC activities or interventions. And so from a program implementer's perspective, we thoroughly welcome cost effectiveness studies as a necessary component of SBC program evaluations. But that notwithstanding, there are a couple of challenges that I will speak to in the next 2 slides from the program implementer's perspective, just to share how we see this, how we try to understand the studies as they're implemented. Next slide. So I think the first challenge goes to Laurie's sort of last point she made around having the accounting system set up for within programs for cost effectiveness studies. Being a relatively new evaluation approach for SBC programs, not having had so much of that done in the past, the skill sets for costing, and not typically part of the trainings that we receive as SBC implementers or as researchers. So there's a lot of lack of familiarity with standards of classification of costs, and exactly how to distribute costs across different program areas. So this sometimes becomes a lot of operational back and forth with the researchers to just understand where do we put what costs and for what activities do we attribute those costs to, just because systems are not set up ab initio to capture them with the cost effectiveness evaluation in mind. The second challenge would be around, before now, typically SBC interventions are embedded within broader program strategies. And you may actually have within the broader program, like a service delivery component, a service delivery program or activity that has an SBC component, or a system strengthening program that has an SBC component. So it becomes a bit tricky to isolate SBC costs when the SBC is embedded across other program areas designed for health interventions. So actually extracting those SBC costs also can be tricky in those contexts. Also, it's a bit difficult to sometimes delineate phases of program implementation, because if you look at a typical program, there's a formative phase, there's a design phase, you go into implementation, and SBC activities may cut across all these components, all these phases of the project, and if you want to look at the cost effectiveness across what the cost is during the formative phase, what the cost is during design phase, some of these phases feed into each other and they're not really distinct in terms of having clear lines. There may be activities that, even though called formative, it's part of implementation, and then there's an SBC component. So those clear lines of phases of programs may not always be clear to easy to delineate for cost effectiveness studies. And then there are varied approaches for SBC, which makes it challenging to find comparable benchmarks. Not different SBC programs use different mixes of approaches and strategies for to implement SBC interventions. So it's hard to find two similar programs to compare because they've done exactly the same thing or use exactly the same strategies for their SBC interventions. Next slide. Depending on the outcomes of focus, cost effectiveness studies may not fully account for the effects of SBC on, let me call them intermediary outcomes like attitudes, beliefs, and intentions. And the changes that occur here may be significant, but missed in a cost effectiveness study. Population-based surveys tend to cover the gaps for that, but if we're looking strictly at health outcomes or behavioral outcomes, those intermediate outcomes, which are quite significant in bringing about the behavior change you want to see, may have been missed in doing that. Sometimes the time frame for cost effectiveness studies are not long enough to really see the changes that SBC will bring about, because it really requires some time for the program to take effect in terms of really shifting, particularly on behaviors that are really not on the radar of audiences from the start. You have to move them through the stages of behavior change that may take quite a while to occur. We also would like to see comparisons between, as we like to see comparisons between SBC approaches, we also think that including SBC, evaluating programs that have SBC versus no SBC, we also show the differential impact of SBC on health interventions that may lack that component of it. And then finally, I would not really call this economies of scale. I would call it scale of intervention would need to be taken into consideration when evaluating results, because if you look at one outcome across, for example, two programs, one who implemented in one country, another one in like 5 countries, and we look at similar outcomes, the scale of the intervention will definitely have an impact on the effectiveness. And I guess this economies of scale also come to play there eventually, but those scales of intervention need to be taken into consideration when looking at cost effectiveness studies. So as we continue to develop these resources for these studies and collaborate with researchers around the SBC studies, we hope to really get to the point where we have really robust studies that demonstrate the impacts of SBC interventions and keep it at the forefront of any design for health programs in the future. So thank you. I'll hand over to Nicole.
Great, thanks, Chitu. It's great to get the implementer's perspective on those challenges around this work. As you saw with Laurie's presentation, many of the tools that we've built under breakthrough research are aimed to address these concerns. And we want to continue with that practice of working with others to help move this field forward. Next. So in that spirit, we hope to have an ongoing dialogue among those working in this area and work towards developing a community of practice for SBC costing and cost effectiveness work. As part of this effort, we're developing short briefs on specific topics within this area. Today, we're going to talk about understanding different cost study approaches and how this is dependent on selecting the appropriate denominators. Forthcoming briefs will cover social media considerations, malaria campaigns, and SBC design related costs. So you can look for those coming up in the next few months. Next. Turning to understanding denominators, the SBC costing guidelines cover the main principle on how to generate the numerator of an SBC costing study, which is typically your total costs. The guidelines also address selecting the appropriate denominator, but the brief that we're discussing today goes into more detail about the role of the denominator and generating the unit cost, which is the average cost of an intervention, service, or output. The reason we focus on denominators in the brief is because the selection essentially determines what type of SBC costing or cost effectiveness study that one should pursue. Next. Here you can see a continuum of different types of denominators for SBC. In the brief, we lay out multiple examples across different health areas, but here you can see we're using examples specific to malaria. And the first denominator looks at program outputs, and these are typically measures of the program reach, like the cost per person exposed to a mass media campaign focused on malaria prevention. Next on the continuum are the costs for intermediate determinants of health behaviors. These are things that Shita mentioned, such as knowledge, attitude, norms, and communication. So an example would be trying to figure out the cost per attitude change around the effectiveness of insecticide-treated nets. Moving on next to health behavior, these are really what SBC aims to change. And here is an example. We have the cost per additional person sleeping under an IT1. And then finally, we have health outcomes or impacts, such as the cost per malaria infection averted or the cost per life saved. So you can see that these are arranged in increasing order of difficulty in measurement, as well as desirability from a health or cost effectiveness perspective. So in the next slides, we're going to focus more closely on the program outputs, behaviors, and health impacts. Studies examining the cost per intermediate determinants are pretty rare. They can be done, and a couple exist in the literature, but we're not going to be exploring that category today. Next slide. So for program output denominators, the resulting study is usually called a unit cost study, and the primary purpose is for budgeting and planning. One can also use unit cost to compare approaches for the same type of intervention. For example, if a mass media campaign focused on youth was being broadcast on 3 different radio stations, each with varying costs, one could determine how much the intervention cost per person targeted to see which station was most efficient at reaching its target audience. Example unit costs listed here are by SBC intervention type, where we often see mass media interventions costed as per person exposed, versus something like interpersonal counseling, which is usually costed as per person participating. And then in terms of the data needed, one needs the total costs, and then they need the monitoring data on program reach in order to generate your unit cost. Next. Moving on to health behaviors. The primary purpose can be for advocating for additional SBC investments within a health area. For example, if you calculate the cost per new family planning adopter or per additional facility-based birth, you can demonstrate the SBC costs needed to achieve these behavior changes to advocate for more SBC investments. Additionally, if you can explore how the cost per behavior change differ by SBC approach, population, or geographic location, and help determine the most cost-efficient approach for behavior change. A few examples of unit costs are given by health area here. And as with program outputs, one needs the total cost of the intervention. And then really the key difference is that in addition to the total cost, one needs an effectiveness evaluation that can examine SBC's impact on health behaviors. Next slide. So now we have the denominators of health outcomes or impacts, and these are what really generate our cost effectiveness analyses. And again, these are very useful for advocating for additional SBC investments, particularly across health areas and intervention types, since one can use these results to compare the relative cost effectiveness of different approaches to achieving health impacts. Example cost effectiveness ratios include the cost for unintended pregnancy averted for family planning, the cost for infection averted for SBC interventions, focused on malaria, HIV, and other infectious diseases. Denominators that are cross-cutting of health areas, such as the cost per life saved, or the cost per disability-adjusted life year averted, or DALY averted. These are particularly useful in comparing to established cost-effectiveness benchmarks. In our work at Avery, we've used the cost per DALY averted in the business cases to compare results to a country's gross domestic product, and then used the World Health Organization's thresholds for cost effectiveness to look at the results. In terms of data needed for cost effectiveness work, one needs either to capture changes in health outcomes or ability to model the health impact via available tools. Examples are the Impact 2 for family planning, the Live Safe tool, and Spectrum. So next. This flowchart can guide you through some key questions to determine the appropriate type of denominator you should think about when approaching an SBC costing study. The first question is, what is the primary purpose of the study? And if the answer is solely for budgeting purposes, then it makes the most sense to focus on program outputs. However, if there are other purposes of interest, the next question is whether there's an evaluation in place to capture changes in health behaviors and outcomes associated with SBC. If there's not one already in place, the next question is one possible given the program budget and administrative feasibility? And if the answers to these questions are both no, then one should again focus on program outputs. And while program outputs from our perspective are less desirable than health behaviors and health impacts, these are still really important and useful because they can be incorporated into our broader understanding of what SBC interventions cost and for program efficiency purposes. So we've relied on a lot of studies on program outputs and collating them to have a better understanding of what SBC costs for the business cases. That being said, if evaluations are currently planned or can be implemented, then we would encourage you to pursue denominators that look at health behaviors or health outcomes. And the key difference between these two is whether or not you can detect changes in health outcomes or if they can be modeled. If so, then health impacts are preferred. And if not, then one should focus on the health behavior denominator. Next. So this was a rather quick overview, but these are the main points covered in the first community of practice brief. And the main takeaway is really that the selection of the denominator for SBC costing really reflects what type of study is being conducted. In our work thus far under breakthrough research, summarizing the existing literature, we have found that more SBC costing research is needed at every level, particularly around newer forms of SBC interventions. When possible, we would encourage people to incorporate costing into their program evaluations to explore cost effectiveness analyses. We've examined a lot of excellent program evaluations from our business case research. And when we go through that literature, often we would find ourselves wishing that some costing had been done as well, so to generate more cost effectiveness. So our hope is to encourage that consideration of adding that element in going forward. Next. So at this point, I'm going to turn the presentation over to my colleague, Michelle Schmidt. Thanks, Michelle.
Thanks, Nicole, and good morning or good afternoon to everyone. So this presentation is basically kind of a case study, and the previous participant has given you a lot of background about costing and cost effectiveness, but this particular one is basically a costing study, not a cost effectiveness. Next slide. So the Mercy Moneros program is a USAID funded multimedia campaign that is conducted by Breakthrough Action, and it focuses on the sexual reproductive health issues that include encouraging open dialogue on the sexual reproductive health issues between adult and youth. One component of the Mercy Moneros program is a youth-led social media campaign that was originally conceived in February 2019 at the Youth Design Challenge during the Francophone African Summit in in Cote d'Ivoire, in Abidjan, Cote d'Ivoire. So, and the study objectives were to calculate, the study objective here is to calculate the unit cost of this MMH program, which is basically videos disseminated via social media in 2 countries in the region, where the study countries are Cote d'Ivoire and Niger. Next. So for the data collection, first we needed to construct a data instrument, and we use the costing guideline principle in order to be able to extract all the elements that were necessary while we were building the costing instrument of this for this study. So the data on video dissemination were captured via social listening reports conducted by Breakthrough Research in partnership with the MMC Search Intelligence. And for this dissemination report, as it has been explained by Nicole, that's where you will be seeing the denominators, the various denominators that we use. And as she clearly explained, depending on which denominator you use, the costing, the unit cost can be very, very, very different. So for the personnel and overhead, we use a proportion of that cost was attributed to the program based on interviews of the stakeholders. And given the issue with potential recall bias, we conducted a sensitivity analysis by varying that personnel level of effort by 5%. That means if they have given us like 10% of their time, we will increase that by 5% and also decrease it by 5%. So we put a 5% margin around the level of effort that they provided. And in terms of the proportion of the total design cost, that was attributed to the 2 study countries, because the program is disseminated in 7 countries. We use the breakdowns of the video reach in social listening reports that were provided to us. Next. For the focus of this program output, the number of exposed to the campaign via social media, we use 3 different denominators here. First, there was the reach, that means the number of screens that the MMH video was entered. But the engagement were the number of times people engage with the post through reaction, comment, share, or retweet. And the views were the number of views of at least 30 seconds. And each video was at least 2 minutes long. Next. So here you'll see in the second column there, the cost in Cote d'Ivoire. The first column gives us the cost categories. We had personnel, consultant, travel, training, and so on. And in Cote d'Ivoire for the MMH program, the total cost was around 31,000. And in Niger, it was around 13,000. So for the 2 countries, the total cost was 44,981. And the higher cost in Cote d'Ivoire is due to the reach and also the proportion of the oil design and production. And there was also the fact that the program started earlier in Cote d'Ivoire, so consultants were higher earlier in Cote d'Ivoire, so they were paid for a longer time compared to Niger. Next. So here you see the different unit costs in Cote d'Ivoire and Niger. And in terms of the reach, you see that in Cote d'Ivoire it was 0.14 cents, and in Niger it was 0.18 cents, and the average was 0.16, which is the third, the last 3 rows there. You see the reach is the lighter green, the engagement is the light green, and the dark green is the views. You can see how the unit cost can be very, very different depending on which denominator you use. Next. In terms of the key takeaway here, this study addresses the gap in the literature on the unit cost associated with the SBC via social media. First, I need to also point out here that we did a literature search and there was nothing related to unit cost of social media in the literature. Substantial differences in unit cost depends on which denominator is used, as I mentioned, and therefore determining the most appropriate denominator for social media will require additional insight on the level of engagement needed to generate behavior change. For this study, having a youth-led design and production like the Mercy Mahuri requires more oversight. So that means one can spend more, but the long-term skill building and capacity strengthening benefits of engaging youth in the design and the production are important to consider. So at this point, I will pass it on to, I think, Amanda.
Yes, thanks, Michelle. And thank you so much to all of our panelists today. You can go to the next slide. As I mentioned earlier, Springboard is where we'll continue these conversations and really foster that community of practice around costing to continue to build the evidence for social and behavior change through costing and cost effectiveness. On Springboard, and we included the link in the chat today, you'll find all of the costing products and resources that were discussed today. And you can also engage with colleagues about these resources, ask your questions, and find answers. And as Nicole mentioned in her presentation, be on the lookout for additional costing briefs coming out soon, as well as for an invitation to a follow-up event to this discussion so that we can continue the engagement around costing for SBC. And before we launch into the Q&A, we'd like to hear from you through 2 quick polls as to what you'd like to hear about next. We want to make sure that we're providing the information and the resources that feel relevant to you and your projects and your work. So we have 2 polls. The first is, what would you like to see as the next topic of discussion? So we have a couple of options here. So first we could talk about the ins and outs of using and sharing cost data. So for example, things like, what do you need to do to get your financial systems ready to track costs for these kinds of analyses? How and what costs do you track? What are the considerations for sharing these kinds of data, particularly with another party who might be doing a cost effectiveness analysis or another analysis? We can also talk about using SBC costing data to make the investment case. So how do or can implementers use the business cases that have been developed? How has it been used? And hear different perspectives, such as from donors or ministries of health, and really try and understand how these resources can be used to make that case. Or we can also talk about SBC costing challenges and solutions that breakthrough research and breakthrough action have come across, some of which were previewed today, but really thinking about what's unique about SBC when it comes to costing. What challenges and solutions have BA and BR found so far, and what's next? And we can use the Q&A during today's webinar to try and make that a little bit more specific. And what format would you like to see for the next discussion? So we can have an instructional webinar, we can have a participatory webinar where we have hands-on exercises, or do a Q&A session or roundtable type event. So we'll leave this open for maybe a minute so that you all can vote, and then we'll move on to question and answer. Okay, Sherry, how are we looking? Okay, I think we can go ahead and close the poll. Great. Okay, great. So, thanks so much for your votes, and we'll use this information to work with our Breakthrough Action colleagues to design a follow-up event around these topics of discussion. So thanks so much. And thank you so much for adding your questions to the Q&A. We'll go ahead and start to address some of those. And so the first one that we'll address, we have a question that came in. Do any of these tools measure costs of changing the environment, the enabling environment? For example, getting a husband to support the wife's use of family planning, which are also important determinants of behavior change.
Yeah, that's an excellent question. I'll start. Like I mentioned, that would fall into the cost per intermediate determinant category. And in my recollection of looking through the SBC costing literature, I can think of a few different studies that have looked at intermediate determinants, but it's definitely like 3 or less that I've seen. And so that's particularly rare, and I do not recall one that focused on the enabling environment. I think it's certainly an interesting area to look into, and I'd be very curious if someone was pursuing that type of study, how to think about like costs per norm change and enabling environment change. I think is an area that would be ripe for interest in the research. I don't know if others have other thoughts or ideas.
Yeah, this is Lori. Let me just add to that. I actually think that question, the costs, would be maybe not easy, but straightforward to gather because it's the cost of the intervention. It's really, in that particular case, I think it's the impact where things are complicated in measuring. But in terms of the costs, it's the cost of your intervention, in my opinion.
Thanks so much for that. A next question. So after nutrition, are there other topics on the list of business cases that Breakthrough Research plans to develop?
I think this is another great question. I think there's a lot of interesting potential given where we are at year 4, midway through year 4, year 5. I don't think we'll be pursuing a 4th business case in this cycle of the project, but really, I think our perspective is that the more these health business cases, as they're developed around health areas, that they can be led to a more integrated model, a more integrated SBC model that we think would be best for the field. Because we see a lot of overlap and efficiencies. Just as you talk about integrated SBC having efficiencies in creating behavior change, we can see that in our model where SBC around antenatal care has implications for malaria, it has implications for family planning, it has implications for nutrition, and other areas, of course, as well. So the more different health areas are explored, the more we can move to that integrated model, which I think will really demonstrate how cost-effective SBC can be. Or did you have any other thoughts on that, or others?
No, that sounds good.
Thanks, Nicole. And I think that speaks to there's several follow-up questions around, I'll just read one of them, but I think to a point you were just making. So if a project delivered multiple impacts across multiple issue areas, is there a way to collectively average all of the cost effectiveness measures into one measure for a project's total overall cost effectiveness, or what does that look like when there are multiple issue areas?
So oh, go ahead, Nicole.
No, go ahead, Lori.
Oh, so I was just going to say that that's when you end up using a metric such as DALYs, which is disability life years averted. So if you have a specific health area like HIV, where you can talk about the cost per HIV infection averted, that's a cost effectiveness ratio that can be calculated, but it really only pertains to HIV. So if you want to look across multiple health areas, that's why this measure, DALYs, was developed. so that you would be able to compare the cost per dollar averted for HIV with the cost per dollar averted for family planning, etc. And then you can aggregate those as well. So if you have an intervention, an SBC intervention that affects both, this is a bad example, turns out, but both HIV and family planning, then you can calculate the dollars averted from each and aggregate them. Obviously, you'd use the aggregated cost as well. But there is another dimension, which is there kind of a synergy, either positive or negative, such that the dollars averted would be higher or lower of this? Is there like a joint effect? And it's actually easier to do a cost of an integrated program, but it's more difficult to kind of separate out those effects because you have to model the dollars. It's not something that can be measured in the field. So it gets complicated, but I think it's very much worth doing because integrated SBC, we see a lot of integrated SBC programs. So trying to examine the full effect accurately of those interventions, I think is really important.
Thank you, Lori. Nicole, anything?
I just wanted to add that this is something that we're working on in the Nigeria work as well as in Niger under the RISE 2 program. And we are leveraging the LiveSave tool to try to look at these dimensions when you're looking across multiple health areas. I think that it's really useful. It's an exciting kind of area to look into. So, keep your eyes open for forthcoming work coming out that is trying to address these multiple dimensions.
Thanks, Nicole. So another question that came in. So while it's understood that this requires specific skills, are the resources shared earlier today designed for any health program implementer to be able to undertake costing and cost effectiveness exercises themselves, or would it need some kind of training prior to accessing and exercising?
Yeah, that's an excellent question. And a lot of that depends, of course, on the complexity of the intervention that's being costed, as well as the, who's going to be undertaking this and sort of whether they have any kind of experience in this type of work. It might not be specific to SBC costing, but familiar with kind of financial categories, et cetera. I think that one could certainly read the costing guidelines and get a sense of whether or not they think if they need something more, if they maybe need to hire a consultant to assist with data collection or analysis. But they are meant to be kind of to enable implementers to think about how do they integrate costing into their effectiveness plan and how to operationalize it as well. So I think, unfortunately, like a lot of questions, the answer is it depends. But that's what we're hoping to move towards. Do you have anything to add, Lauren, to that?
I think the only other thing might be to make sure to include your finance people in these discussions. I find that a lot of times the researchers, the impact effectiveness people are not connected with the finance and accounting department. And those people actually understand exactly the kinds of questions and issues that are raised in the costing guidelines. So I would just encourage at the beginning for them to be able to help set up the system such that you can track your spend according to your analysis plan.
Thanks, and I think we'll have time for just one final question. One came in earlier. So when you were aggregating your costs for this, did you include advocacy and other activities in your SBC definition, or what costs were included there, sort of broadly or generally?
That's a great question. For the business cases, we were looking at SBC intervention categories, and usually advocacy fell into a broader category of what we called SBC packages. So a lot of course, people know a lot of SBC is done using multiple strategies, including advocacy. And so that's usually where it was captured as part of the broader packages. And we find that packages of SBC tend to be more effective than just mass media alone or IPC alone, et cetera. So that's how it was captured there. And in looking at some of the cost effectiveness work that we're doing now, we are capturing costs associated with advocacy as well. But again, these are broad SBC packages. So I haven't seen much in the literature or anything that I can recall offhand that is looking solely at the impact of advocacy on health outcomes, but maybe others have a recollection of something like that. But usually it is embedded in broader packages, is my understanding. I know that we have 2 more minutes. I just saw another question pop up about how do you cost the time of community health volunteers doing SBCC? And that's another great question. The guidelines cover how to capture volunteer time, and that's a decision that one needs to make when doing a question study. If they're doing financial costs of just what everything costs versus doing economic costs and incorporating that time. So I would just refer you to there to get a broader explanation and help you through that process.
Thanks, Nicole. I think we have several questions that we weren't able to get to with an answer. And so, as I said, we'll follow up with those answers on our Springboard platform. So please do utilize that link to Springboard, join our community of practice where you can find all of the resources discussed today, answers to the questions that we did answer and didn't and weren't able to answer today in time. And thank you everyone for joining. We are really excited about continuing to build the evidence for costing and cost effectiveness for social and behavior change. Thank you and have a great rest of your Thursday, everybody.